everyone. In this session, I am going to discuss spread of the tumor, that is metastasis. I will be discussing three types of spread of tumor, the three routes of spread of tumor: hematogenous, lymphatic, and transcoelomic. So let's start it. Before coming on the routes, let's define metastasis. What is the definition of the metastasis? How you are going to define metastasis? So what is metastasis? Metastasis is distant spread. So spread of the tumor by invasion in such a way that there is discontinuous, multiple secondary tumors or masses are formed at the site of lodgement away from the primary site. The word to be picked up here is away. The word to be picked up here is away. So let me tell you, this is a human body. For example, we are drawing a human body. For example, this is the human body. Okay, this is the patient. Now just suppose there is a primary tumor, let's say in any organ, let's say in the primary tumor in the abdomen or in the GIT, right? This is the primary tumor. Now the primary tumor, the cells of the primary tumor will dislodge some of the cell and they will enter either in lymphatics or they will enter in the blood vessel or through the cavity only. They will transmit to multiple secondary organs, and multiple secondaries can be formed in the brain, in the bones, in the liver, in the lungs, in multiple tissues. Now you can notice the multiple secondaries are there. All these secondary are away from the primary tumor. This is the primary tumor. So the word to be picked here is discontinuous and away. They are discontinuous, they are away, they are not in continuation. If they are in continuation, it is known as local invasion. But since they are discontinuous, it is known as metastasis. So the other name of the metastasis is distant spread. So it is the discontinuous, multiple secondary tumors or masses are formed at the site of the lodgement, which is away and discontinuous from the primary tumor. Now metastasis is the most reliable feature of malignancy. There are many differences between benign tumors and malignant tumors. We know there are two types of tumors, the benign and the malignant. The most reliable and short feature to differentiate between benign and malignant is metastasis. Benign tumor never show metastasis, malignant tumor can show metastasis. So it is the short or the most reliable or the hallmark feature of the malignant tumors, not benign. So as I told you, benign tumor never metastasis. All malignant tumors show metastasis except two. There are two exceptions, ultra important. The first is the glioma of the CNS, glioma of the brain, and second, the basal cell carcinoma of the skin, the rodent ulcer, the tear drop ulcer or rodent ulcer, basal cell carcinoma of the skin. So these are the two tumors which are malignant. So ideally they should metastasize, but we have not seen even a single case of metastasis of these two. But looking at the morphology, these are not benign, these are malignant. So the glioma and basal cell carcinoma are the two tumors which are malignant, but they never show metastasis. These are the exception. So point is that all benign tumors do not show metastasis. All malignant tumors show metastasis except two, the glioma and basal cell carcinoma. Now what are the routes of the metastasis? There are three routes of metastasis: the lymphatic, the hematogenous means blood spread, and transcoelomic. There are three routes. So I would like to draw the same sketch diagram again. So you can see this is a rough sketch diagram of a human body I am drawing. For example, let's say this is a female body and she is having the tumor in one of the breast. Okay, now what are the ways it can spread to other organs or it can do the metastasis? Either the tumor cells can spread via lymphatic, or it can spread via blood vessel, or it can spread via transcoelomic route. What are the three routes? So either the tumor cells can spread to all other organs via lymphatic, or it can spread via the blood vessel, that is hematogenous route, and spread to other organs, or they shed directly in the cavity, the pleural cavity, the abdominal cavity, and via cavity it is moving to other organs. This is transcoelomic. So these are the three routes in front of you: lymphatic, hematogenous, and transcoelomic. Lymphatic is via lymphatic vessels, hematogenous is via blood vessels, and transcoelomic is via open cavity. So tumor cells will dislodge from the primary tumor and spread to multiple secondary organs via what? Is it lymphatic, hematogenous, or transcoelomic? That is the three routes. So the same you can see it here. This is the tumor. These are the tumor cells. The tumor cells will dislodge. They will enter either the lymphatics or they will enter the blood vessel, right? This is hematogenous spread and this is lymphatic spread. and they will, here also it will spread to multiple organs, and via here also it will spread to multiple organs. The transcoelomic is not shown here. There are 3 routes, right? Now we know there are 2 type of malignant tumors in human body, the carcinomas and sarcomas. Carcinomas are the tumors of the epithelial origin, and sarcomas are the tumors of mesenchymal origin. So carcinomas spread by lymphatic route and sarcomas spread by hematogenous route. Okay, so that is the thing. Now we will see the details of them. The first is the lymphatic spread. So I will give you the details of the lymphatic spread, then I will give you the details of the hematogenous spread, and then the third one, transcoelomic. Transcoelomic route is rare. Normally carcinoma spread by lymphatic, sarcoma spread by hematogenous, transcoelomic is rare. So let's start with lymphatic route, the details of the lymphatic route. As I told you, carcinoma spread by lymphatic route. You have to learn that. Now what is the pattern? So the natural route of the lymphatics draining that particular organ and producing regional nodal metastasis is the most common. For example, for breast, the regional lymph nodes are axillary, so axillary are involved. For lung, the regional lymph nodes are paratracheal and perihilar, so that are involved. So the regional lymph node of that particular organ are involved. So if someone is having breast cancer, the nodes which are involved are axillary. If someone is having lung cancer, the nodes which are involved are paratracheal and perihilar. So the regional lymph nodes are involved. That is the first thing. The second, the first lymph node. Now there are many lymph nodes. One by one they will be coming in the vena. So let me draw a lymphatic. Can you see? This is a lymphatic vessel I am drawing. So one by one the lymph nodes are coming. You can see the lymph nodes are coming one by one here. You can see. Okay, this is a lymphatic vessel. Imagine this is the primary tumor. This is the primary tumor. The cells from the primary tumor will come, and the first node they will involve all the nodes which are coming in the way, the natural way. So all the lymph nodes will be involved one by one. But the first node which is involved is known as sentinel lymph node. So sentinel lymph node is of greater importance because by checking the sentinel lymph node, we can predict whether the other lymph nodes are involved or not involved. If the first lymph node, the sentinel, is involved, there is a probability all of them ahead are also involved. But if the first node is not involved, if the sentinel lymph node is not involved, so there is less chance or no chance that the further lymph nodes are involved. You know, so especially in the breast cancer, imagine you are a surgeon, you are operating a female having a breast cancer. So you will take the primary tumor out of the breast, either by performing lumpectomy or mastectomy. But whether axillary lymph nodes have to be taken or taken out, yes or no completely, that depends on the sentinel lymph node. So during frozen section, we can test the sentinel lymph node intra-op only. If the sentinel lymph node is involved, the lymph node should also be removed. If the sentinel lymph node is not involved, lymph node should not be removed to prevent the further morbidity. You got it? So that is the relevance of the sentinel lymph node. So sentinel lymph node is the first node in the regional lymphatics, is known as sentinel lymph node. It is of greater importance in breast cancer, as I told you, vulva cancer and melanoma. It was first discovered by a person, a scientist known as Gould. So you can see here, this is the primary tumor. So if the lymphatics are following this route, this is the sentinel lymph node. If the lymphatics are following this route, this is the sentinel lymph node. And if the lymphatics are following this route, this is the sentinel lymph node. So the first lymph node coming in the route is the sentinel lymph node, right? So usually, I told you, the tumor cells involve the lymph nodes in a sequence. The sequence is the natural sequence only. So in the sequence, the first lymph node which is coming in the way, that is involved first, then second, then third, then fourth, so on, right? But rarely from the first directly to the third. It is an example of skip metastasis. So rarely, if there is an obstruction in the main pathway, there can be a skip metastasis by collaterals takes place. So it is very rare, but it can happen. So let's learn a term, skip metastasis. Sometimes the local lymph nodes may be bypassed. You know, they are bypassed because of the venous lymphatic anastomosis and the skip anastomosis. The skip metastasis can take place. Now in a lymph node, do you know the structure of a lymph node? In the lymph node, this is the capsule. Just below the capsule, the follicles are there. The follicles are formed by the lymphatics. Can you see? These all are follicles. These all are follicles. So follicles are formed by the lymphocytes. Lymphocytes arrange themselves in a circular pattern and form the follicles. So which portion of the lymph node is involved first by the tumor cells? So the answer is subcapsular sinus. Can you see? This is the capsule. Please see. In this diagram, this is the capsule. And these are the follicles. You can appreciate this is the follicle, this is the follicle, this is the, where are the tumor cells? You can appreciate these all small tumor cells are there. I'm marking with green color. So just below the capsule, you can see the tumor cells are there. It is known as subcapsular sinus, right? So here also in this diagram, you can see this is the lymph node. You can appreciate these all are the capsules. You can appreciate, and just below the capsule, it is the subcapsular sinus. In the subcapsular sinus, you can see the tumor cells are there. The tumor cells are present in subcapsular sinus. It's a very important question. So these all are the important points in the lymphatics. What we have learned? The first point we have learned the carcinoma spread by lymphatics. Okay, the first point we have learned that. After that, it is in sequence. In sequence, usually it is involved. The regional lymph nodes are involved. Sometimes, rarely, there is a skip metastasis. Sometimes, rarely, and in a lymph node, the subcapsular space is first involved. So these are the important points we have learned in lymphatic spread. Now coming on hematogenous spread, that is blood spread. So sarcoma spread by hematogenous spread. By hematogenous spread, sarcomas usually spread, not the carcinomas. Carcinomas spread by lymphatic spread. Now in the blood vessel, imagine this is the primary tumor. This is the primary tumor. Okay. Now you can see here I am drawing a vein, and here I am trying to draw a artery. So what is the preference of the tumor cell? Will they preferably spread via vein to other organs, or will they preferably spread by via artery to other organs? So it's a common sense. So what is the preference of the tumor cells? The preference is the vein. The answer is the vein. So tumor cells prefer to enter in the vein and spread to multiple organs as compared to artery. So venous involvement or via venous, the spread is more common as compared to artery. The reason is very simple. Veins have a thin wall. We all know veins have a thin wall, but the artery have a very thick wall. So tumor cells will get a resistance in the artery, but in the vein they can easily penetrate. So leaving the primary tumor, they enter in the vein very easily as compared to the artery, because artery have a thick wall. So the same thing is written in front of you. The veins are more commonly involved as compared to artery because veins have thinner wall. So the tumor cells can penetrate it easily, in contrast to arteries which have a thick wall. Here also you can see in the diagram, this is a vein having a thin wall. This is the artery having a very thick wall. So that is the hematogenous spread, the first point you have to learn. The second thing, which organs are involved? So most commonly liver followed by lung. These are the two most common organ involved because of the venous invasion. Hematogenous spread. Why liver is most commonly involved? Because of the portal drainage. What do you mean by portal drainage? You know, the blood of complete GIT drain. It drain in the portal vein, and via portal vein only it drain in the inferior vena cava. So can you see the complete GIT, the stomach, the spleen, the pancreas, small intestine, large intestine, they all first drain in portal vein. Via portal vein, it goes to liver, and from liver, it goes to SVC, IVC. It will go to IVC. So portal vein, so if there is malignancy in any of the GIT organ, if there is a malignancy, just suppose in stomach or in spleen or in pancreas or in intestine or any GIT, so tumor cell will dislodge, they will go in the corresponding veins. From the corresponding vein, they will go in portal vein, and from portal vein, the first metastasis in the liver. That's why liver is most commonly involved organ in hematogenous spread, especially in GIT malignancy, because of the portal circulation. So this is the reason. And second is lung is second most commonly involved. Now, apart from GIT, if tumor occurs in any other organ of human body, any other organ, this is the tumor, just suppose, tumor cells will dislodge and they will go in vein. All the vein, where they go, we know all the vein of human body, they go in SVC, IVC, and via SVC, IVC, they will go in right side of the heart. First, they will go in right auricle, then they will go in right ventricle. From right ventricle, they will go in pulmonary artery, and they will go in the lung and form the secondary. So tumor in any organ, if it is spreading by hematogenous route, if it is spreading via veins, you can see it is going to the lungs. So the first organ which is coming in the way is the lung, you know. So the secondary most commonly formed in the lung. So secondary is most commonly formed in two organs in hematogenous route. Most commonly it is formed in liver. Second most commonly it is formed in lung. Most commonly it is formed in liver. Second most commonly it is formed in lung. Right. So these are the two most common organ involved in hematogenous route. You can see this is the liver mats. Multiple liver mats are present like this. And you can see these are the lung mats. Multiple lung mats are present. Liver is the most common organ involved. Lung is the second most common organ involved. So that is the thing. You can see various organs are also involved apart from these. You can see liver is most common, lung is second most common. Apart from that, brain can be involved, bone can be involved, kidney, adrenal can be involved. You can see multiple secondaries are there via hematogenous route. You know, blood is going everywhere in the body. So via blood, they can reach any organ. But technically, most commonly, the GIT tumors will go in the liver and other tumors will go in the lung. So liver followed by lung are the two most commonly organ involved in hematogenous spread, right? So we have seen the important points in lymphatic spread. We have seen the important points in hematogenous route or blood spread. Now coming on transcoelomic spread. Now coming on transcoelomic spread, the third one. What is transcoelomic? There are three possibilities in transcoelomic spread. Let me tell you the three possibilities. Number one, through the body cavities. The best example of the body cavities is Krukenberg tumor. Let me draw a diagram for you to show you what is Krukenberg tumor and what is the spread through body cavities. That is one of the transcoelomic route. So let me draw a female in front of you. This is the GIT, this is the stomach and intestine of this female. Okay, and these are the ovaries of this female. Imagine this female is having a stomach cancer, that is the primary cancer, the gastric carcinoma, that is primary. Now what is happening? The tumor cells are shedding in the cavity. It is not going via blood route. It is not going via lymphatic route. It is shedding in the cavity and via floating in the cavity, the abdominal cavity, the pelvic cavity, it is involving the bilateral ovaries. So in the bilateral ovaries, it's the secondary formation. It's the secondary. These are two secondary and there is one primary. There is one primary that is in stomach. So this triad is known as Krukenberg tumor. So basically patient presents with three tumor, one in stomach and two in ovaries. The stomach one is the primary and the two ovaries are the secondary. And the route of the spread is not blood, not lymphatic, it is through direct cavity. That is known as transcoelomic route. So via cavities it is there. The best example I told you, it is through the natural feed. The peritoneal cavity, the pleural cavity. You can see the Krukenberg tumor. So the tumor from the stomach, the cells are coming and involving the ovary. So you can see the bilateral ovaries are very big. So basically the carcinoma of the stomach seedling into multiple, both the ovaries. The secondaries are formed in both ovaries. So it's a triad. That is the first thing in the transcoelomic route. The second thing, spread via CSF. You know, the CSF is present in the subarachnoid space in the brain and the spinal cord. So this is the brain and this is the spinal cord. This is central nervous system. Now we know three meninges are present around the brain and the spinal cord. One of them is arachnoid. So it's pia meter, then arachnoid, then dura meter. So in the subarachnoid space, CSF is present everywhere. This is CSF. The CSF is present. The CSF is present in the subarachnoid space. Okay. Now just suppose tumor present in any portion of the central nervous system. The tumor cells will be shed in the CSF. And via CSF, it will go to some other portion of the CNS only and form the secondary there. Now see the definition. Definition wise, it's discontinuous. The two masses are discontinuous from each other and the secondary is formed at the point of the lodgement which is away from primary. So you can say it's a metastasis. And what is the route? Is it blood? No. Is it lymphatic? No. Is it cavity? No. It's CSF. So CSF will also come in this transcoelomic route. The same diagram is shown to you also here. You can see this is the primary. And it is shedding in the CSF. Via CSF, it is forming the secondary. So tumor of the ependymoma and leptomeninges can spread via the CSF. That is the second thing. And third is implantation. It is rare of the rarest. You know, for example, there is a surgeon. The surgeon is using a scalpel or needle or sutures in one of the cancer patient, right? And at one side of the cancer patient, not without sterilizing or without cleaning the scalpel, the same scalpel is used to cut some other site in the patient body. So surgeon's scalpel is transmitting the cancer cell from one portion to another or one human to another. So that can be implantation. That is very rare. So what are the three routes we have studied? We have studied three routes of metastasis: the lymphatic, the hematogenous, and transcoelomic. In transcoelomic also we have seen three. The first one is through cavity. The example is Krukenberg, through cavities. The second is CSF. And the third one is the implantation via surgeon's scalpel or surgeon's needle, implantation. So that is the three type of the transcoelomic route. In lymphatic spread via lymphatic vessels. In hematogenous spread via blood vessels. So we have seen the details of all of them. Now it's time to see the mechanism of metastasis. So let me tell you mechanism of hematogenous route. Hematogenous route which is seen in sarcoma. There are 8 steps. We will be seeing all 8 steps one by one. Here 1, 2, 3, 4, 5, 6, 7, 8. Total 8 steps are shown, 2 steps in each diagram. You can see 4 diagrams in front of you. So 2 steps are shown in each of them. The first step is the clonal proliferation and angiogenesis. So can you see here? First understand this diagram. In this diagram, you can see this is tumor. Okay. This is tumor. I'm drawing with the red color. These are the tumor cells. These are the tumor cells. You can see this is the blood vessel. Appreciate the blood vessel. And you can appreciate this is the endothelial lining of the blood vessel. Between the tumor and the blood vessel, you can see a extra. You can see a extra tissue. It's the extravascular tissue is there, right? So the tumor cell first, a cluster of the tumor cell will loosen. From the tumor cell, a cluster of the tumor cell will become more aggressive. That is step number 1. So what is the step number 1? Tumor heterogeneity. From the tumor, the cluster of the tumor, few cells become aggressive and they lose. Few cells become aggressive and they separate. They become more aggressive. Then they lose from rest of the tumor. For example, these 2 tumor cells or 3 tumor cells, they are becoming aggressive. So they will lose. So what do you mean by losing? What is the glue? What is holding the cells together? So for holding the cells together, there is a protein required known as E-cadherin. So there is loss of E-cadherin. Loss of E-cadherin takes place. Mutation in E-cadherin or loss of E-cadherin. E-cadherin is acting like a glue. If there is loss of E-cadherin, the tumor cells loosen from each other. After loosening, they enter the extravascular mass. You know, you can see they are entering the ECM. You can see this yellow color tissue is ECM. Okay. So it's extracellular matrix, ECM. So you can see the tumor cells which become aggressive, which become loosened, they interact with the ECM with the help of receptors. The receptors are laminin, fibronectin, vitronactin, collagen. So receptors are present here via receptors. First they interact and after entering they degrade the ECM and enter inside them. For degrading they have the enzyme collagenase, gelatinase, and finally they enter inside the ECM, right? After entry in the ECM, they secrete a autocrine motility factor AMF via which it will enter inside the blood vessel. So it will enter in the lumen of the blood vessel and they rotate from here and there. They flow freely from here and there. But what if the tumor cells are the foreign? Now, my question is that why not WBC kill them? WBC do not kill them because they are very smart. They will form a thrombus and cover themselves with RBC and platelet. So the WBC will not recognize them that they are foreign, they are tumor cells. So they cover themselves with RBC and platelet, the circulating host cell, to prevent from the immune attack by the WBC. That is thrombus formation. At a distant site, they will go out. Again, this is known as extravasation and they will form a secondary there. They will do the survival, they will produce the growth factor, they will do the proliferation and they will form a secondary here. So see the 8 steps are in front of you. You can see in step 1, few tumor cells become aggressive. Okay. And step 2, they lose from each other. For loosening, there is loss of E-cadherin. After that, in step 3, they interact with the ECM. In step 4, they enter inside the ECM by degrading it. Step number 5, you can see they enter inside the blood vessel through autocrine motility factor. Step number 6, they form a thrombus to protect from the immune attack. Step number 7, they extravasate at some distant site. And step number 8, they grow there. So can you tell me the 8 steps? They are in front of you. The step number 1 is aggressiveness of a clone. Step 2 is loosening from others. Step 3 is tumor ECM interaction. Step 4 is degradation of ECM. Step 5 is entry of tumor cell in the lumen of the blood vessel and then thrombus formation. The next step is the extravasation and growth at the distant site. So please learn the 8 steps in front of you. I am repeating the 8 steps. Here also it's a longitudinal diagram showing the same 8 steps. You can see this is a tumor cell. The first thing, they become aggressive. Okay. Second thing, they lose from each other. After loosening, they enter, they interact with the ECM, they degrade the ECM, then they enter in the blood vessel, they form a thrombus there, they move to some other site, they extravasate and they grow. I hope you got the 8 points. That's all about metastasis. So step number 1, it's a clone of the tumor, a subset of the tumor. Some tumor cells, they will become aggressive. Number 2, they loosen from each other by loss of a protein known as E-cadherin. Number 3, they interact with ECM. Okay. Step number 4, they degrade the ECM by producing certain enzymes. Step number 5, they enter inside they enter inside the lumen of the blood vessel, okay, by producing autocrine motility factor. Inside the blood vessel, they form a thrombus. Now they move to some distant site. There they extravasate. Extravasate, they come out. And after that, they grow there. They grow there, they proliferate there by producing growth factors. So please learn the 8 steps. Try to understand the diagram. Try to understand the mechanism of each step. That is metastasis by hematogenous route. That's all about metastasis, the spread of the tumor, and the steps and the mechanism of the metastasis. Hello everyone. I hope you understood this topic with crystal clear concepts. Now, if you want the notes of this topic and all my YouTube session notes, then you can click on the link which is pinned in the comment box. Thank you so much for your kind attention, for your patience, for your valuable time. Now here a QR code is provided to you. You can scan it if you wish, and via scanning it, you can connect with me on various social media platforms like Instagram, Telegram, WhatsApp, where I share educational content which will be very useful for you. So if you wish, you can take the snapshot or you can scan it directly. And here is a contact number provided to you. You can save this contact number. It's 98330-32948. This is for WhatsApp support, chat support. It is not for calling. So if you have any doubt in the topic which I'm teaching you in this session, and if you have any doubt in other topics also, in pathology, pharmacology, microbiology, PSM, medicine, you can text your query here. And if you have any topic in your mind and you want me to take that topic, to schedule that topic in YouTube, so you can also text that topic here. So if many students are demanding the same topic, we will schedule it soon. So thank you so much. Wishing you all the best. Bye-bye.